This is the continuation of embryological defects. We are going to study about tracheo-esophageal fistula. It is a congenital defect. Let's learn what is meant by fistula. It is the abnormal connection between the organs. There are 5 to 6 major types of the tracheo-esophageal fistula. In this we learn type A, esophageal atresia. In this, the esophagus at the both sides is blind-ended. The esophagus ends do not communicate with each other. Next, type B. The upper end of the esophagus has fistulous connection with trachea while the lower part is blind end. You can see this diagram. Upper connection, there the esophagus is connecting to the trachea where the lower end is blind end. Next, type C. In type C, the proximal part of the esophagus is blind-ended, but at the lower part there is fistulous connection between esophagus and trachea. Here we can see the lower part of the esophagus is connecting to trachea while the upper part is blind end. Next, type D. In this, the both ends of the esophagus communicate with trachea. Here we can see this, the upper part and the lower part of that fistulous communication of the esophagus with trachea. Next, type E. We can also call it as H because the esophagus is functional but the fistulous communication at a single point, which may be at the upper end, lower end, or at the middle. In other words, we can say it esophagus is patent, which means functioning, with fistulous communication with trachea. You can see there is a H shape we can see here, the fistulous communication of trachea and esophagus. Next, type F. Trachea is normal but there is a stenosis of esophagus, which means the trachea has nothing to do with, there is just a stricture or stenosis, which means conjunction or constriction of the esophagus. Next, we can see about the associations of the tracheo-esophageal fistula. You can remember as vectral mnemonic, in which V is for vertebral defects, A is for anal atresia, C is for cardiac defects, T is for tracheo-esophageal fistula, and R is for radial hypoplasia and renal agenesis. Next, we have the clinical features of the tracheo-esophageal fistula. Here, the patient present with polyhydramnios due to inability of the fetus to swallow amniotic fluid. Neonates choke, drool, vomit the first feed. Cyanosis is secondary to laryngospasm. In most commonly, the TEF is majorly associated with NMYC gene. Investigations. Failure of NG tube to pass. In chest X-ray, TEF allows air to enter stomach. Echocardiography and contract study. We use dynosil. In this, failure of NG tube to pass is a clinical investigation we use majorly. Treatment is child require gastrotomy for feeding. Fistula identified and resected through right-sided thoracotomy. If the gap is small, then lower segment is anastomosed with upper blind end. If the length is inadequate, then colonic or gastric transposition is done, which means we will cut a part of the colon or gastric and connect with the gap between the fistula. These are the types of tracheo-esophageal fistula. Please like and subscribe. Thank you.